Good evening, everybody, and welcome to another worldwide WiSH brought to you by WITS Sport and Health at WITS University. A big thank you up front to our sponsors, Asino and Lita pharmaceutical companies, who've given us a grant to cover the technical costs of these broadcasts. And thank you to all of you for joining us again this evening. Those of you that were on Thursday's excellent presentation by Professor Louise Burke may have noticed I was looking a little bit nervous, and that's because I didn't have my usual technical backup in Dr. Robin Saggers, but gratefully he's back today, so I'm more relaxed and looking forward to welcoming our guest. As you know, we encourage interaction, so please make use of the question and answer facility. Post your questions there rather than on the chat group, and we'll group those and make sure that as many of them are answered by our speaker as possible. I think you'll agree that the topic for this evening is very timely, as in South Africa and in the Southern Hemisphere, we're going into summer and much hotter temperatures, and particularly in the environment that we're in at the moment, where a lot of sport traditionally played in the cooler winter and autumn months has been put on hold and now brought forward into summer in slightly different environmental conditions. So we're going to hear today a little bit about exertional illness, and we're going to look at 4 different types of illness that fit into that category. And in my opinion, there's no one better in the world to talk to us on this than Dr. Francis O'Connor. Dr. O'Connor has an extensive CV, which I'm not going to read to you, but I've known him for long enough through the American College of Sports Medicine and the American Medical Society for Sports Medicine, and fortunately through his visits to South Africa as well as a guest of the South African Sports Medicine Association, who co-present these webinars with us. Dr. O'Connor has a military background, highly qualified and highly decorated, and he's in the fortunate position as a sports and exercise medicine physician of having access to the resources of the US military. And particularly in an area that we're going to discuss this evening, that has massive advantages. So he brings with him this evening extensive experience in sports medicine. He's just been telling us how he's been in the NBA bubble in Orlando, where they've been completing their tournament and league for 3 weeks, and he is currently in Virginia, which is his home base. So we welcome Dr. O'Connor to our WiSH webinars. We thank you for giving up your time on this Tuesday to join us, and we ask you, as one of the educators in this field of ours who knows the most about exertional illness, to please share your screen, and we look forward to your presentation. Thank you, Dr. O'Connor.
Okay, thank you very much, John. I appreciate that invitation or that introduction, and I hope everybody can see my screen at this point. John, can I get a thumbs up that you can see my screen?
Perfect, thank you. We're all good. I'm going to mute and stop my video and hand over to you.
Wonderful, thanks, John. So as Dr. Patricio said, I'm going to be speaking this evening about exertional illness, and this is one of my favorite topics, and it's my passion right now with the United States military at Uniformed Services University. And what I hope to do is to cover 4 clinical problems and then share with you a lot of the lessons learned in the military and how we're approaching a lot of these issues right now. As John did mention, I did serve in the United States military for actually 34 years in uniform. I'm out of uniform right now. I'm retired colonel, but I still work at Uniformed Services University, the health sciences here in Maryland, which is the home of our medical school, and I support the Department of Defense. I have no disclosures for my talk this evening. I'm going to start with 4 cases, and these cases are really going to be what we're going to be focusing on tonight. This first case occurred in 2011 in the United States. You see this young man here. This is Wes Leonard. He's a star athlete at a high school in the United States in the Midwest. He had just made a winning shot in a basketball game got in the team lineups and was walking over across the court to shake hands with the losers. He started walking and then he collapsed. The second case is Korey Stringer, which many of you may well be familiar with. This was football back in 2001. This is a picture here of Korey Stringer that was actually in the newspapers, not of the day of his collapse, but the day before his collapse. He was a professional football player, was unusually hot in the Midwest, he had a heat index here to 110, was vomiting, staggering, and he was brought into a shelter by an assistant athletic trainer on that particular day, and he was complaining just of dizziness, weakness, and actually just reclined and was humming to himself. Dale Lloyd, who you see here in 2006, collapsed on a football field in Texas when he was practicing. Big tradition with American football is after football practice, many of the kids line up to do consecutive 100-yard sprints, running 16. And early on in this tradition, he started showing some sign of distress, breathing heavily, complaining of severe tightness in his legs, and eventually he collapsed during this exercise. And then finally, a more recent case, this is Doug Brenner. January 2017, was out at football practice. You know it's not going to be a good football practice when the coaches are bringing out oxygen tanks and garbage cans. Very aggressive practice. As he said, I couldn't even move my arms after the second day. Arms were so swollen, I couldn't even take off my own shirt. And he had a collapse. So we're going to review some of the principles this evening on sports injury prevention. I think that we all need to be aware of as sports medicine providers, whether or not you're a team physician or an athletic trainer or another professional in this field. We're going to identify some of the common etiologies of collapse, and I'm really going to focus on these four: exertional sudden cardiac death, heat stroke, as John alluded to, sickle cell trait with collapse, which is an area of interest of mine, and then finally we're going to wrap up with exertional rhabdomyolysis. So prevention, that's really what it's all about. And certainly in the United States military, the United States Army, you know, we have 1 million men and women in arms, whether or not that's active duty or reserve, but we have a relatively big team and we need to preserve that team. So we focus on prevention. And these are the three levels we traditionally talk about: primary, keeping a disease process from becoming established. That might be something like right now, there's such a press in the world, let alone the United States, on getting a vaccine for COVID-19. We anticipate that, but that would be primary prevention. Secondary prevention, someone like a team physician just checking a blood pressure during a pre-participation examination, screening for hypertension. And then tertiary, we're going to talk about, this would be having that cold water immersion ready for someone who's in the throes of a heat stroke, and we're going to try to make a difference. I would argue this is one of the ones that's forgotten, and certainly one of the more important ones that I deal with as a leader in the United States military, and that's quaternary prevention. This is an action taken to identify the patient or population at risk for over medicalization or to protect them from some invasive medical intervention. We're looking at that very hard right now in the United States, in the military and in the NCAA. What are going to be the cardiac workups for kids that have had COVID, whether they've been symptomatic or asymptomatic? We want to find the right mix, and we certainly don't want to do any harm either. Because as we know, anytime you introduce a medical provider, there's always the opportunity for iatrogenic harm. And of course, that's our first rule from Hippocrates, and that is first do no harm. So let's get to Wes Leonard here. And unfortunately, Wes Leonard died of a sudden cardiac arrest from a dilated cardiomyopathy. So this is uncommon, obviously. I used to say rare, but it's a relatively uncommon event. If it does happen, of course, you make it into the front page of the paper. It's catastrophic for a community. It's estimated here in the United States that the risk of athletes dying of a sudden cardiac death is about 1 in 50,000. It's of major concern, obviously, because of my final bullet there on the bottom, that it's the leading cause of exertional death in young athletes. And it's what we worry about as medical providers. We know from a lot of the literature, this goes all the way back to Steve Van Camp, who was a cardiologist with ACSM back in 1992, and this is relatively consistent with most of the literature. Tends to be the boys over the girls, 5 times higher in male athletes. Tends to be collegiate athletes, as opposed to high school athletes. Many of these entities mature with time, and there may be more stress in the collegiate ranks. Non-cardiac deaths, which we're going to talk about, like exertional heat illness, are going to be a smaller number. And for reasons we don't understand in the United States, football, basketball, and African Americans appear to be at greater risk for sudden cardiac arrest. Now, this is a classic paper from perhaps the leading thinker in the United States on hypertrophic cardiomyopathy, let alone the world, Barry Marin, where he took a look at nearly 2,000 deaths. And you take a look at these 2,000 deaths in young athletes, and you follow this down here, the majority of these deaths are going to be cardiovascular. And when we take a look at these cardiovascular deaths, most of them are going to be exertional as opposed to non-exertional. And traditionally, we're taught that it's going to be hypertrophic cardiomyopathy, coronary anomalies, possible HCM, possible myocarditis, which we're certainly concerned with COVID-19. And this is generally the way we approach prevention by identifying the epidemiology and coming up with strategies. This was published by Marin back in 2009 in Circulation. But there's been some change in that literature, and I think it's things that we need to be aware of. This came in 2011 from Rob Eckhardt. Rob Eckhardt was a military cardiologist, took a look at the Department of Defense on what were the leading causes of death. And actually, the leading cause of death in the military under the age of 35 was this sudden explained death. Interestingly enough, after sudden explained death, it was early atherosclerotic disease, then followed traditional causes like hypertrophic cardiomyopathy. Now, this was validated in 2015 by Kim Harmon. Kim Harmon's a primary care sports medicine physician. She's the team physician at the University of Washington. And what she found in her study looking at an NCAA cohort, the National Collegiate Athletic Association, was once again the most common cause of death was not hypertrophic cardiomyopathy, but rather autopsy negative sudden explained death. And of course, this makes it tricky when it's unexplained as to how do we go about actually screening for and intervening for these autopsy negative sudden explained deaths. The other thing that Kim found that really was a game changer for many of us with our thinking, that the incidence of sudden cardiac death, remember I told you 1 in 50,000 in young athletes, Division I male basketball players, 1 in 5,200. So dramatically different in male basketball players, in particular Division I African Americans. So as primary care physicians, we're thinking about prevention, and what are our main tasks with prevention? Well, I have them listed here on this slide. That's going to be execution of universal precautions with exercise acclimatization, environmental acclimatization, attention to hydration, workload adjustments, endorsing, certainly in the United States, where I am right now in Northern Virginia, every high school in Northern Virginia has a certified athletic trainer. And as we're going to see with my last entity, as I talk about rhabdomyolysis, the call out for certified strength and conditioning coaches to actually write the programs that our young athletes are going to endorse. Now, this exercise acclimatization and environmental acclimatization cannot be overemphasized, and we're going to talk about this with rhabdo as well as heat. But certainly in the area of COVID-19, leveraging more time for quarantining, we are leveraging both these entities with environmental and exercise acclimatization and actually seeing some decrement in exertional death, and I'll talk about that as we move through this lecture. Secondary prevention is where certainly physicians get involved, team physicians working with athletic trainers, doing the pre-participation examination, where we're picking up that stethoscope, looking for kids with underlying disease that may be occult, and we're going to be considering some secondary screening. This is always a target of interest in the United States with potential electrocardiography, echocardiography, et cetera. We follow right now the 5th edition of the pre-participation physical evaluation. This was just published last year. It's endorsed by all the major medical societies in the United States, and it provides us with guidance on how to do an appropriate pre-participation physical evaluation. Now, let's talk about what you bring when you do this pre-participation examination for a secondary screen. Now, many of you may think this is what we do in the United States military, but no, this is not what we do. This was done years and years ago We don't line people up like this anymore. But we do follow the recommendations that are endorsed in the PPE manual. And this is from the American College of Cardiology, American Heart Association, this 14-point history and physical examination. And at a minimum, you see across the United States that people are following this 14-element examination. You see here by performing a very careful personal history, family history, and physical examination to endorse that hopefully this athlete is free of occult disease. We also in the United States are really in tune with guidance from the NCAA. This is Dr. Brian Hainline here. Brian Hainline's a neurologist who leads, he is the chief medical officer of the NCAA and certainly leading the fight right now with COVID as we try to reintroduce activity. But he published back with a number of people that you may recognize here, such as John Dresner and Aaron Bagish, consensus recommendations on cardiovascular care. And every NCAA institution is accountable for these guidelines. Interestingly enough, it's important to point out that special tests to include echocardiography and electrocardiography are not mandated in our current paradigm in the United States through the NCAA or the National Federation for High Schools. That being said, they can be endorsed if there is a good program that has good follow-up, et cetera. So a quick comment here on the role of electrocardiography. The American Heart Association's been out front on the role of electrocardiography as a screening test. I talked about the secondary screen looking for occult disease, but also quaternary prevention and making sure we do no harm. So the cardiologists in the United States published this. This was back in 2014. And again, had the feeling that there was insufficient information to endorse universal screening. Oh, excuse me, let me go back. But once again called out that with individual quality controlled programs where there is good support, good follow-up, involvement of cardiologists and good community resources, that this is something that should be perhaps endorsed and studied. This became a real issue for us in the United States in the role of electrocardiography, and we were divided on whether or not this was going to be something that was going to be beneficial or something that potentially induced more cost and more harm. We actually put a panel together. Dr. John Dresner out of the University of Washington and myself led this panel looking at this. And I think the most important conclusion we reached was that not all athletes carry the same risk. And this is important. I'm sure there are many family physicians who are listening to this talk right now. We all know when we see patients, we risk stratify, we apply different screening strategies to individuals who have different risk. And I think the same can apply to athletes. I know as a team physician for a local university here in Northern Virginia, we apply electrocardiography screening to our high-risk athletes, which are our basketball players and our football players. We do not routinely recommend that endorsement for other athletes. So the possibility of endorsing screening that accepts and recognizes this differential risk, I think is important. And it's been a paradigm shift in the United States. This publication in the British Journal of Sports Medicine really echoes this difference in relative risk that you see here going from a high school athlete down on the bottom all the way up to relative risk to an African-American collegiate Division I basketball player, that relative risk is dramatically different. Now in the United States, I'm sure just like South Africa, we do not make policy on relative risk, we make policy on absolute risk. But this is something you certainly can't ignore, and you see in the United States, many institutions who endorse different screening regimens based on an appreciation of this relative risk differential. Now, the reality, however, though, with secondary screening, whether or not you use EKGs, echoes, cardiac MRIs, whatever, is this still is a very challenging problem. It's a great publication, New England Journal in 2018 by Malhotra, taking a look at nearly 12,000 adolescent soccer players who started screening at age 16. And you see here that these kids who were screened got a health questionnaire, they had physical examinations, electrocardiography, and echocardiography. There were 23 deaths in this cohort as they followed them over time. They had 8 deaths were attributed to cardiac disease. When they took a look and went back and looked at the 8 deaths, They actually found 6 of those deaths with sudden cardiac death had had a normal cardiac screen, meaning they had a normal echo and they had a normal EKG. So this still remains a tremendous challenge when you have a very low prevalence of disease in your screening. It's tough. And that leads to tertiary prevention. And I think this is where certainly there's agreement across the board that if you had to spend your dollars on prevention, this is where it clearly needs to go. That's bystander CPR, access to automated defibrillators, knowing where they are and having training on how to use them, and execution of the emergency action plan. All NCAA institutions have to have an emergency action plan that's practiced, rehearsed, documented, and this is where we really have the opportunity to save lives. You have to have a plan. It has to be written down and it has to be practiced. And now at our university, we just practiced 2 weeks ago, going through these scenarios. This is a scenario we have for the Marine Corps Marathon, our collapsed athlete master algorithm. But having these plans in place are absolutely critical. Most importantly, that everybody on the team understands them and they're practiced and they're rehearsed. Now, this is the sudden cardiac arrest of Hank Gathers. And I'm sure some of you have seen this, but Hank Gathers, this is hard to believe, 30 years ago in the United States, but it still resonates. And you're going to see Hank Gathers here go up and make his last dunk. This is Hank Gathers. Hank Gathers was the leading rebounder and the leading scorer in the country in 1990. Certainly going to be a first-round draft pick in basketball, and you're going to see an exertional collapse here in just a second. But unfortunately, a lot of tough lessons learned, and you got to think of yourself either as the trainer or as the team doctor out there covering this event on where is that AED, what am I going to do? So you see Gathers go down very quickly and he sits bolt upright very quickly. That's a clear sign of an arrhythmia that took him down. The athletic trainer is out. This is the aunt. And then you're going to see shortly the sports medicine fellow is going to come out. Now you see Gathers is demonstrating a rather classic presentation, and that is agonal breathing and seizure activity. Here's the sports medicine fellow asked to cover the game that evening. He's now tonic. Here's the coach. But I think if you're a sports medicine provider, you're an athletic trainer, this is a scenario that you need to go over to your mind every time you walk on that court. Where's that AED? What am I going to do when you are out there? And this is going to be a game, of course, on national TV. This case drew a lot of scrutiny and a legal settlement. It was on TV because you're going to see a defibrillator brought out. This is his mother, brought out, and unfortunately, a defibrillator was not used immediately. But every time I know that I walk out on the court or I'm talking to our sports medicine fellows, we go through that scenario. Where's the AED? Do I know how to use it? Are the batteries charged, et cetera? So the next case we're going to talk about here is Korey Stringer. And of course, Korey Stringer, unfortunately, had an exertional heat stroke and he passed away. Now, this is a huge issue for us in the United States military. As I mentioned, we have nearly 1 million men and women in arms in the United States, and that's in the United States Army. This is something that's published every month called the Medical Surveillance Monthly Report, which goes over all the epidemiologic data in the military on medical, as well as musculoskeletal injuries, and this just reflects heat strokes. Bottom line is in 2019, we had 507 exertional heat strokes. This remains a considerable problem for us. Most of our training is going to be in the southeastern United States. Those of you who've been here know that it's quite hot and humid in places like Georgia, Alabama, Louisiana, where we have a lot of our training bases. Oops. Now, this is Fort Benning, Georgia. We actually just stood up a heat center of excellence down in Fort Benning. We take a look at some of the data coming out of Fort Benning. Fort Benning is the leading source of heat injuries in the United States military. It's in Georgia. But you look at the data here over on the left, it tends to be the men over the women. But that being said, you know, that's 2 compared to 1.85. I just had a young lady in our heat chamber yesterday. It was a West Point cadet. She was female. And the last 2 people with heat strokes I've tested have both been females. Tends to be the young, but the young are the ones that are out there accepting most of the risk. And when we take a look at the military services, it tends to be the Army and the Marine Corps, again, who have some of the greatest risk out on the ground. Interestingly enough, when you take a look at this data down below and you look at heat illnesses over this time period, a lot of heat illnesses here in the southeastern United States. But when people go over to the Middle East, most of these people have been screened, they've been protected, they're acclimatized, operations are generally nocturnal, and heat illnesses are relatively small in number over in a combat theater of operations. Now, unfortunately, it's not just the military. This is a publication back in 2013 by the Korey Stringer Institute taking a look at deaths. There's 54 deaths in American football since 1995. And it's relatively predictable when you take a look at these football players. It's August. It's when kids are just starting their training before they start football. A third occurred more than 2 hours into practice during August. So this is when kids are certainly just starting their acclimatization. And when you take a look at football rates compared to every other sport in the United States, it's 11 times greater than all other sports combined. So football is our major risk. I would also argue that exertional heat stroke, unlike sudden cardiac arrest, which can be occult, this is arguably the most common cause of preventable non-traumatic exertional death in American sports. Now, we do a lot of cooperative work with militaries across the world, but certainly one is the Israeli Defense Force. The IDF has studied exertional heat stroke in their population, 2 items present in 100% of fatal cases. Number one, physical effort unmatched to physical fitness. Sometimes we know that these kids just aren't up to the challenge. We're starting to look at gaits when people are doing runs, that if you're not making a 2.5 mile gait with a certain time period, that we're actually starting to identify and pulling you from the run, because we can identify kids that just don't have that physical fitness for the effort we're demanding. And then of course, where we come in as medical providers is the absence of proper medical triage, our failure to recognize that someone's in trouble. A lot of risk factors have been described in the literature. I just want to point out a few. Poor physical fitness, and we're certainly seeing this in the United States. Physical fitness in high schools is not what it used to be, and a lot of people believe some of our problems with heat stroke and exertional and musculoskeletal illness in the military is really a reflection of our population and the population that is not physically ready when they join the military. Lack of acclimatization, again, most of our training is going to be in the South Atlantic United States, where it's very hot and humid. We pull kids from all over the United States, and this lack of acclimatization can be a real issue coming from a place like North Dakota going down to Georgia. Obesity is certainly a problem in the United States. Terrible problem for us in the military, dealing with more and more kids. It's estimated that perhaps now only 20% of the population in the United States coming out of high school is eligible for military service. And part of this issue is because we have a lot of kids that are obese or overweight. But this is also proven and been demonstrated to be a major risk factor of exertional heat illness. Illness is huge. Again, we're drawing people from all over the United States coming down as a cohort. Diarrheal illness, upper respiratory illness. We're certainly very concerned about COVID-19, but occult illness certainly is a risk factor for why someone is going to have heat stroke that day. Drug use, supplements, federal-like products, ADHD drugs, medications for allergies, all of these can impair our ability to deal with the heat. These become considerable problems. And of course, our kids in the military are not going out in shorts. Helmets, body armor, these are all risk factors. And same thing with football players here who also have the added burden of clothing that becomes a risk. So I mentioned obesity and overweight is a considerable problem. This is one study done out of by Cheryl Bednow out of Fort Bragg in North Carolina, that if you're overweight or obese during the first 90 days of service, you've got 3 times the risk that you're going to have an exertional heat illness. Obviously, if you're covering high school football and you see a young man like this in August, this is a young man that you've got to keep your eye on, who's certainly going to be a risk. Meds. Again, we have more and more people in the United States military who are now deployable and who are out there exercising and functioning as soldiers who are on medications now. Used to be in the old days that many of these things limited deployment, limited participation in the military, but not anymore. So we need to know as providers things like all these medications and how they impact on your ability to sweat, to generate a intravascular volume or control your brain in interpreting that you're hot and you need to slow down. Supplements are a huge issue once you get out of basic training. This is a picture here of supplements that were taken out of a locker of a young man who collapsed in Afghanistan. And when you take a look at these supplements, and of course, most of us know, and people who use supplements, they don't use one supplement, they use multiple supplements. How all these supplements interact, God only knows. So primary prevention, this is where we come in as trainers, as physicians, as leaders, trying to make sure that we're properly leveraging acclimatization. We're paying attention to our work and exertion tables, following our flag system so that we can adjust the work and the hydration, and leveraging things like pre and intra-event cooling strategies. This is a table that comes out of the United States Army Institute of Environmental Medicine out of Natick, Massachusetts. And this guidance is used throughout the military to take a look at what is the workload, what's the heat category, and making an adjustment on how much work should be done, what's the work rest cycle and a hydration cycle to avoid things like exercise-associated hyponatremia, but trying to prevent heat illness and prevent collapse to the greatest number possible. And commanders are held to this standard. NATA, which is the National Athletic Trainers Association, has really tried to attack that data that I showed you up front with people having trouble in August in the second hour by introducing guidelines on leveraging acclimatization, this being propagated across the United States, trying to introduce common sense acclimatization guidelines to coaches and trainers to make sure that we can protect kids against the throes of exertional heat illness. We try to leverage in the military and the civilian community pre and inter-event cooling strategies. Here you see an air vacuum device in a military Humvee. Again, this does not treat heat stroke, but it can try to keep people cooling. We're looking into microclimate cooling clothing to keep people cool and leveraging things like a slush during exertion to keep people cool. Certainly this is very important as well in the United States, in the military and in the civilian community. Races are quite common. Physicians and trainers need to recognize do not start temperatures. This is a publication by Bill Roberts, published in the Signature Journal of the American College of Sports Medicine, that you should need to know your local environment, your local unseasonably hot environment where it might be unexpectedly hot, that we might induce a mass casualty event, and where a physician might intervene to say, you know what, maybe today is not a good day to have this race. Secondary prevention is paying attention to what's going on with the teams that you're taking care of, or the platoons in the military, looking for heat illness as it pops up, identifying people who might be endorsing bad practices. In the military, we leverage the buddy system, trying to take care of one another, looking for a change in personality, which might be the earliest clue to exertional heat illness. And secondary prevention, all over the military, we leverage heat dumping. Here in an NFL stadium, you once again see a vacuum control device for a hand to try to keep someone cool. So in the military, we leverage what's known as heat dumping. This is up at Fort Benning, Georgia, leveraging cold showers regularly as troops are moving through training sites. And this is another strategy that's done in Fort Jackson, South Carolina. This is, as you see here, just a device where you can roll up your sleeves and put your arms in. This is the arm immersion cooling system. We have these all over Army and Marine posts, and in between training lanes, soldiers, Marines, and others who are training are encouraged to use these devices to keep cool. This is something, again, that was designed by the military for the military, but is quite popular. So the other thing we do in the military is we leverage ice sheets. Okay, and all over the military, it's just a training video here. You're going to see that when troops go out in the field, they are educated to protect one another. Here you see a cadre member looking out for a unit who's training, but that vehicle behind has ice sheets that are ready to go. So you see these ice sheets, and you're going to see how they're executed here when a troop goes down to create essentially a ice burrito while they're waiting for 911. Here, this is a cadre who's looking at his troops, looking for signs or symptoms of someone who might be in trouble with exertional heat illness. Again, major problem. I talked about 507 heat strokes, and you can multiply that by 4 to 5 to get the number of heat exhaustions that are identified. But as you see here with this drill sergeant, so much comes down to leadership and paying attention and awareness. So here's the ice sheet technique that we teach in the United States military. All over, you either see barrels or you'll see chests like this that have ice sheets ready to go to treat that troop while 911 is being called to evacuate that patient for cold water immersion. Because many of the training sites obviously are going to be in remote areas. And here you see the drill sergeant calling for 911. Okay, tertiary prevention is you are ready. This is now where that ice sheeted individual is coming in there in the throes of heat stroke and you're trying to save a life. Rapid cooling intervention can be done by first responders. This is all in the attempt to save a life and reduce end organ injury. So this is the real deal when someone comes in with an exertional heat illness. This is at our Marine Corps Marathon. Certainly you've seen this in South Africa working max participation events. But when these people come in, they are in the throes of a heat stroke and on their way to dying unless someone takes prompt intervention. It is certainly a heat attack. So here you see, this is our Marine Corps Marathon Medical Tent, and we're leveraging a lot of the lessons learned from the Navy down at Quantico, which is a major Marine base. You see here 3 cooling stations set up. At the marathon, we use the ice water dousing technique where the water is brought up and over. I'm going to show that to you in a minute. But same thing like a sudden cardiac arrest, you need a good emergency action plan and a team that is well trained to handle this emergency. So this is what it looks like down at Quantico, which is literally just about a half an hour from my home. So Quantico is perhaps the largest training post for Marines as well as Marine officer candidates. Here you see the doctor or the PA. Individual is being brought over. You've got an ice water dousing set up. We use a gurney that has a semi-permeable membrane where water can be ladled up and over. Takes a big team to do this. Not uncommon. The narrator saying, expect the patient to be violent. Anybody who's treated a heat stroke knows this can be a full court press. You have a team here, and this first and most important thing is going to be get that rectal thermometer in so we have an idea of where we are. The physician is up top, managing the airway as trying to maintain control of the scenario with the team. Everybody else is going to be controlling the individual here and applying cold water dousing technique. The water is going to be ladled up and over in addition to ice being provided to the individual. But anybody who's managed this knows it can be a very scary endeavor and it takes a team. Certainly takes a team, and you got to be prepared for a patient to seize. Got to be prepared to handle an airway. In the military, we like this as opposed to deep cold water immersion. We like the dousing technique in case we need to get an AED on the chest. Okay, I'm going to move on to the next problem just in the essence of time here. And this is Dale Lloyd with football. Again, Dale Lloyd was running when he collapsed, complaining of muscle tightness in his legs. This was an exercise collapse associated with sickle cell trait. Sickle cell trait is generally benign, but there's without any doubt, sickle cell trait has been associated with complications to include exertional sudden death, exertional rhabdomyolysis. We've published on this in the New England Journal of Medicine, splenic infarction at altitude, hypowastenuria, which is the inability to completely concentrate your urine. You see here on this slide a picture of 9 African-American football players at the time of this publication who had thought to have died of exercise collapse associated with sickle cell trait on the football field. A lot of key publications on this, one coming from the military. John Kark was a military hematologist published in the New England Journal of Medicine in 1987, validating that your risk as an African-American sickle cell trait positive was 30 times greater of death than the risk of an African-American who was sickle cell trait negative. Kim Harmon had a comparable publication in the NCAA. also demonstrated 37 times the risk, an African-American with sickle cell trait positive versus an African-American without sickle cell trait. She also sadly showed that a sickle cell trait in an African-American football player, absolute risk over 4 years of 1 in 805 of a sudden death event. Now, it's important to keep perspective on sickle cell trait. So I'm going to go back to Barry Marin's initial slide here on cardiovascular or collapse in general, and looking at cardiovascular. You have to go all the way to the other category here to take a look at these collapse events here. And these collapse events with others include sickle cell trait related rhabdo, but also in this category are things like drownings and lightning strikes and suicide. So it's not common. That being said, I can tell you for the United States military in 2019, we had a very difficult year. There were estimated to be 7 deaths associated with sickle cell trait. These are 2 deaths here that you see here on the right. These are 2 young naval recruits at Great Lakes, which is in Chicago, who both died during a 1.5 mile run, and they all exercised in a temperature controlled environment. I had an opportunity to interview and investigate the medics who took care of both these young ladies who collapsed. Both were very similar during their 1.5 mile run, struggling in the event, falling behind, collapsing, being encouraged to continue, and then collapsing eventually to their death, unfortunately. That being said, these events are rare. And we also know from the United States military, there's a large cohort that was published in 2018 by a colleague of mine, Daryl Singer, that we know that there are thousands of people in the United States military with sickle cell trait who are active, who are serving proudly. This one study showed they actually deployed more frequently, greater lengths of time, remained in the service longer. In this one study, no significant difference in crude mortality rates was demonstrated. That being said, I showed you the 2 pictures of the young ladies who died at Great Lakes. This is the last NCAA athlete who died at Cal Berkeley. These deaths do pop up, and they are tragic when they occur. What do we know about them? They tend to be in those people who are unconditioned military recruits or deconditioned athletes in a pre-season exertional training. It tends to be with repeated intense exercise bouts with limited time to recovery or some unaccustomed exercise challenge for these individuals. Most of the time, it's going to be an unusual muscle weakness or pain that they experience. And one of the real keys to this lecture is that, as opposed to Hank Gathers, when you saw him collapse, most of these collapses initially are going to be a conscious collapse. A lot of question in the literature, is it heat, is it hydration, or is it intensity? This remains unknown, but certainly heat, hydration, and intensity are all co-founders to this problem. Randy Eichner, who is a former team physician at Oklahoma, really a leading thinker on this issue with the American College of Sports Medicine, a hematologist, University of Oklahoma, really believes that the issue is exertion, and it's unintended exertion on the part of that individual. They have this inability to catch their breath or recover. We are very interested in sickle cell trait. We have a large project underway right now with the National Heart, Lung, and Blood Institute, where we're studying sickle cell trait collapses in the United States military. And this is very interesting to me. As I mentioned before, it's 1 in 50,000 across the board with sudden cardiac arrest. I also know in the United States military, it's 1 in 90,000 recruits will die within that first year, 1 in 90,000. We know that the risk of death in those with sickle cell trait is 1 in 3,000. So it's 30 times that risk. But the interesting thing to me is it's 1 in 3,000. So the question becomes, what about the other 2,999 who had a comparable load but did not die? So this has caused us to really look at this issue hard and wonder about genomics and trying to rethink this as a single hemoglobin gene mutation, but are there other genes that may travel with sickle cell trait that put someone at risk? So we're looking at this right now. My bottom line up front is that not all sickle cell trait athletes may not be the same, but this is a question that we are exploring right now. So with primary prevention, we screen. Right now in the NCAA, as a result of this death I just described to you with Dale Lloyd, part of the policy that came out of litigation was that people are screened for sickle cell trait, and we do that. But bear in mind that this was not a popular decision in the United States. The American Society of Hematology came out, did not feel this was warranted, and felt it had the possibility of actually being discriminatory to the African-American population. When you start labeling people, you have the potential to do harm. We talked about this quaternary prevention up front. So many people were concerned with this entity. That being said, we just published this article. This was in Sports Health in 2020. It's one of my fellows, Ben Buchanan. And we looked at the NCAA data, looking at this screening from 2000 to 2019. And we actually found, as you see here in the conclusion, that the incidence of death in D1 football players had decreased significantly since the onset of screening. Now, why was that? Was that due to the screening effort? Was it education to the coaching staff? Was it education to the individual? We're not sure, but we can validate for you that this intervention of screening did make a difference in lowering the rate, statistically significant, of death in D1 football players. So with that being said, all of us in the United States are acutely aware of guidance from the NCAA. This is published in the Sports Medicine Handbook, last published in 2014 and 15, but this is the guidance. We try to encourage those with sickle cell trait that should set their own pace. And in particular, this one call out here, be excused from performance tests, such as serial sprints or time mile runs, especially if these are not normal sport activities. Now, this is a very interesting call out, especially in the military, where we try to treat everybody the same. So I think the most important thing for us in the military, where we do performance tests and we do time mile runs, is certainly making sure that we leverage acclimatization for those individuals. Secondary prevention. The single most important point of secondary prevention is recognizing someone who's struggling. And if they're struggling or they're taking a knee, okay, those people warrant intervention. All people actually warrant intervention with a healthcare provider. One of the traditions in the military has been, if someone's struggling, encouraging them to get up and keep going. But in particular, this can be an invitation to a disaster in someone with sickle cell trait who's demonstrated to you that they're struggling. They need help. They don't need encouragement to get back up and continue. The other strong call out here on secondary prevention is prohibit punitive exercise. One of the leaders in this area is Philippe Kahns, who's done a lot of work in hydration. As I mentioned, many people with sickle cell trait are hypoestenuric. They have difficulty concentrating their urine. A lot of attention to this. We certainly do not want to limit water. We want to encourage water ad libitum, as this has been demonstrated in exercising SET carriers to actually normalize their blood viscosity and help to lower the risk for complications. Tertiary prevention is the focus right now in the NCAA as well as in the military. And that is recognition when someone is down, being ready to intervene. We've got algorithms that are published on this right now, but perhaps the single most important part of the algorithm is recognizing that someone is down, intervening, and that early intervention call out is getting help to the individual and providing oxygen. We now have in the US Army and in the NCAA, the access you have in all NCAA training rooms, you have oxygen provision. And in the United States military, not only do our medics carry AEDs, but they also carry portable oxygen before that ambulance gets there, because this can be a life-saving intervention. We don't have a lot of evidence to support that, but that is the consensus, and that's our recommendation right now moving forward for those people with collapse with sickle cell trait. I'm going to show you a video here that's relatively powerful of what a collapse with sickle cell trait looks like. This is an individual who was participating in a team competition. And you're going to see here an exertional collapse secondary to a fulminant rhabdo, complaining that his legs don't work. And of course, it's going to be in the great tradition that he's encouraged to continue. And I'm going to blast through some of this again in the essence of time. Now, this individual here, again, is part of the team. He always runs at the front, but now he's in the back. This is him right here. And that was the first clue to the team that something is wrong with this individual. He's now about 6 minutes into exercise, but he had to carry a body, a dummy body, 5 flights of stairs up during this training exercise. He's now at a shooting range, and he's going to shoot. I'm going to move this forward in the essence of time. because he's going to go back down, and now he's coming back up a hill, and you're going to see him way in the back here. He's now about 9 minutes into exercise as you're going to see him coming up the hill. This is a cadre member. This is not our individual. Okay, so here you see him. And again, this is a guy run a 5:30 mile, 5:30, but he is struggling. He's 9 minutes into exercise. And think if you're the provider, the trainer, the ATC covering this event. So these are his teammates encouraging him to keep going, but he's 9 minutes in. And I want you to really concentrate on watching his legs, because you're going to see an example here of an acute fulminant rhabdomyolysis involving large body parts, in particular his legs. Notice his legs are working, but again, 9 minutes in. So he's being encouraged, if you can't hear that video, by his colleagues to keep going, because the team has to all get to the box if they're going to compete to shoot. Now you see his legs are starting to completely fail. But watch him when he collapses. So legs are gone, but he's still alert. He's still talking. He can hold himself up, but his body is in failure. So again, this is that conscious collapse that you need to recognize. And now you can see he's up, he's conscious, but his legs don't work anymore. They are done. Okay, so this individual, he needed fasciotomies, upper part of his legs, lower part of his legs, needed to go to the operating room twice. He had a CK approaching 600,000. He was lucky to live. But that's an example of a fulminant rhabdomyolysis associated in someone with sickle cell trait. That's quite dramatic. Last case, and this will be very quick, John, so we'll have time for questions. Doug Brenner, football. Again, this is exertional rhabdomyolysis. It's become a real focus in the military and in the NCAA. This is a major concern in the military. As I mentioned, problem to the left, many kids are not fit, and we are seeing more and more rhabdo in the United States military, and this can be a real issue for us as we try to maintain readiness. But it's not just the military. This is a classic study in the University of Iowa, where during preseason, the trainers had these kids doing 100 squats, 20 rep max, put the great majority of these kids in the hospital with rhabdomyolysis. This was a study that we took a look at in the military with an ROTC unit. They were all doing a classic workup or a classic workout with a 1 mile run, 100 pull-ups, 200 push-ups, 300 squats, followed by a 1 mile run. They had all done it before, but on this particular day, all of them had to do it, but now they were timed, all put on the clock, and there was pressure. And by putting pressure and putting a clock on these individuals with this extreme exercise, over 30% ended up in the hospital. So exertional rhabdo is not uncommon. Priscilla Clarkson wrote about this, called The Perfect Storm, on why one particular day someone develops with rhabdo when they haven't had it before. Certainly experience level, intensity, duration all contribute. We know that eccentric exercise can be problematic. I've talked about some non-exercise related factors such as illness. We worry about COVID-19, underlying upper respiratory tract illness, sickle cell trait I just described, drugs, myopathies, nutraceuticals, all can contribute to this perfect storm. Primary prevention became a huge issue for Dr. Hainline as several cohorts broke out with rhabdo, and it made national news. Brian Hainline, the chief medical officer of the NCAA, came out with his policy guidance in January 2018, and he identified several very important points, and that is that trainers, doctors need to be aware of vulnerable periods. Kids new to the program, coming back to exercise after an illness, coming back after spring break, Christmas break. These are periods where kids can get hurt. Leveraging work to rest ratios early on of 1 to 4 to give people an opportunity. And most importantly, Dr. Hainline mandated in the NCAA that these workouts were going to be written by people who know what they're doing. They're certified in writing these programs. These writings need to be documented in writing. Secondary prevention with rhabdo, it really becomes hydration, I think, is perhaps our most important intervention. Tertiary prevention, you know what you're doing. We, as John knows, we're very interested in exertional rhabdomyolysis. We've just published a guideline here for exertional rhabdo in Warfighters that we used. It's updated in 2020. This is our website, and we walk exertional rhabdo through soup to nuts. This is our new website up on all exertional illness, the Warrior Heat and Exertion Related Event Collaborative, where we try to synchronize everything in the Army, Navy, Air Force, Marines with regards to the entities that we've discussed with good guidance. My conclusion, John, as I studied this over the years, in the end, the critical variable for exertional illness to me is relatively simple, and that is leadership. I just don't think we cannot overestimate the value of the drill sergeant, the coach, the athletic trainer, and their role in pushing kids too hard. We've got to be careful with what we do, because as we know, these athletes and these kids will do what we ask. We published on this recently in 2020, exertion-related illness, the critical role of leadership, and I emphasize here followership as well. The followers have a role as well and a contribution, but when you start looking at cohorts of people who've had exertional illness, you cannot underestimate the role of the leader in this. This was a publication that literally just came out. Barry Bowden, Scott Anderson, team physician at Oklahoma, taking a look at non-traumatic exertional fatalities in football players. And when you go back and you take a look at the fatalities, non-traumatic fatalities, when do they occur? Coach supervised conditioning sessions. It's not during the games, it's during the conditioning sessions. And this is where coaches, trainers, and others have a great opportunity to intervene. So with that, I will conclude. John, I'm going to turn it back over to you. I hope that was helpful.
Dr. O'Connor, that was more than helpful. That was absolutely superb. And I think you had us absolutely riveted there and opened our eyes to a number of situations that we would want to avoid. But I think many of us were asking how well prepared we would be for scenarios like that. And perhaps before we get into the questions, I'll just start with a comment that says that I think whether we're a team physician or we're a physical therapist or a trainer watching this presentation is how well prepared are you to manage such scenarios? Have you got your pre-participation evaluations in order, protocols in order, CPR, AEDs, and how often is it practiced? I think that was a very important point that you made. It's all very well having these things on paper, but how well are they practiced and how ready are you when the time comes? I think that's an important point, and it certainly wasn't lost on me. So thank you very much for that. Just some questions that have come through. The first one, you commented about supplements, and there's quite a lot of enthusiasm about pre-workout supplements and that sort of thing. And I think you mentioned the concoctions that people use. Do you have any experience either in sporting scenarios or in the military with anabolic steroid use, and whether that's a predisposing factor to exertional illness and collapse?
John, that's a great question. I'm going to throw a little bone out to our website. We actually, John, have for the military, what we call OPS, Operation Supplement Safety, is on our CHAMP website, where we have a lot of great evidence-based information. I would add this, John, that what we do, we look at a lot of exertional illness, and I am absolutely not shocked anymore on the relationship with heat stroke, as well as exertional rhabdomyolysis with the role of pre-workout supplements. In fact, I love to hear it from a troop. Hey, doc, I took this supplement. Now I've got some reason, I've got an opportunity for education. Now, that being said, John, we take these supplements that the troops will bring us, and we have the ability with a lab to analyze them. Okay, so that athlete may not think they're using an anabolic steroid, but it amazes me how many of the products that we study are tainted with anabolic steroids. And that's the problem, of course, with supplements, is that you have no good control, at least here in the United States, on what the heck is in that supplement. So I don't see an awful lot of troops because they know they can get in serious trouble if they're taking a frank anabolic steroid. On the other hand, I am absolutely amazed by how many anabolic products are in supplements that kids have no idea are in there.
Okay. Yeah, I think it's certainly a red flag, and there are some supplements that are better regulated, but there are many out there that we don't know what's in them. And as you say, the anabolics are certainly tainting many of them. Is there any risk to dropping body temperature too quickly? Someone's asking in the ice baths, when you've got heat stroke, dropping that temperature too quickly, is that a risk?
That's a great question, John. You know, I know a number of people worry about dropping temperature too quickly, but my read of the literature and everything coming out of the military, as well as Korey Stringer Institute, is that we want to drop the temperature as quickly as possible. Most people are recommending stopping cooling at temperatures of 102 to 102.5 to avoid overshoot, but I don't know of any good literature to support the fact that you can drop the temperature too quickly. I don't know, John, what's your experience been there?
I don't have a lot of experience with it, but I think at the temperatures you're talking about, I agree with you that you need to try and drop that temperature as quickly as possible, bearing in mind that it's gone up very quickly as well. You know, so I do think bringing it down is the priority.
I think if I can add one thing, John, just in my experience at the Marine Corps Marathon and down at Quantico, is that there's always a little rectal delay, you know, with temperature, always a little rectal delay. So that core may be moving faster than what you're getting feedback for. So that's one point. The second point, when you're cooling someone, they will start to cool, but that cooling curve doesn't go down like this. It kind of is very slow to start for the first 5 to 10 minutes, that there's very little decrement. In fact, the temperature may initially be going up because of that rectal delay. But once it starts to go down, that rate starts to pick up quite dramatically. So it's normally about 0.3 cc per minute that you see a decrement. But again, it's a curve that kind of is slow to start and then it drops off rather precipitously. So it's something you need to pay attention to clinically.
What about the use of IV infusions to drop temperature? So cold IV infusions as opposed to immersion.
Yeah, that's another great question. I can tell you in the United States military, that's a strategy that we are using right now. We're using chilled saline out in the field when kids are picked up, that when the ambulance arrives, they'll start chilled saline. And we have good literature to support the fact that if you've got chilled saline in the field en route into the hospital emergency room, that we actually have shorter lengths of stay. So that is a strategy that we are currently using, chilled saline. Okay, but it's confined at this point to our ambulances. If you get into the hospital, at least in the military hospital, the big question is going to be whether or not you're going to do intravascular chilling with big lines, femoral venous lines. And that's by far and away going to be the exception. But that's going to be the decision for the clinician in the emergency room.
Okay.
Over.
We have a question about diet, in particular ketogenic diets, and the risks associated with those in terms of heat stroke or heat illness. Is there an association that you know of?
John, I can't give a good answer. I wish my colleague, Dr. Patty Doyster, was on, but I can't give a good answer to that, to be honest with you, John.
Okay, that's fine. A lot of the examples you gave highlighted an increased risk of these exertional illnesses in male athletes and in African-American athletes. The reasons behind that, you mentioned some of them. Can you just perhaps elaborate a little?
Yeah, I tell you, John, this is something I've been studying here because we have an opportunity where I am, where we do a lot of the return to duty evaluations on kids who have had heat stroke and rhabdo. And I'm always fascinated by personality. And I'm fascinated by people who push and will not listen to their bodies. And I'm trying to always query from that individual, what signals did they have? So as far as male versus female, you saw that 2.02 versus 1.85. It's a small difference. I don't have a great answer, but I do worry with men that they tend to overpush and may not listen to their bodies. That's just speculation. And we are researching this and trying to learn more about personalities and how they will drive through. As far as African-American athletes, I think we've seen that in particular with sudden cardiac arrest. And these are unexplained reasons to my knowledge, John, why African-Americans have more sudden cardiac arrest than Caucasians. So not completely understood. I know here in the United States, there are thoughts about genetics, there are thoughts about healthcare disparities that may contribute with screening, but it's probably multifactorial. I don't have my finger on it, John, other than recognition that it's real.
You will know that Tim Noakes did a lot of the work on hyponatremia, and we have a question on hyponatremia and whether the rehydration in the management of things like sickle cell trait may create a risk of hyponatremia. What's the experience and what does the literature tell us about that?
Okay, so I'm trying to get into that question. So that's the rehydration with sickle cell trait in particular, aggravating hyponatremia?
This is the particular question is related to sickle cell trait and the rehydration strategy. Has hyponatremia ever been a risk or been shown to be a risk as a result of that?
Yeah, that's interesting, John. I haven't seen it, and I have not seen that pointed out in the literature, to be honest, at this point in time. I think the principal interventions that we are pushing and that you see pushed in the NCAA for sickle cell trait are going to be early oxygen, making sure that we have intravenous access with hydration. The general rule of thumb with the military and with races, of course, is to have an ISTAT sodium to avoid hyponatremia. But I haven't seen that, John, to be honest, hyponatremia associated. The real issue, John, that I see as a military provider is the confusion that people have with a collapse with sickle cell trait versus the collapse associated with heat stroke. And those being mixed and confused. I see it coming up all the time. But the hyponatremia, I got to be honest, John, I haven't seen that as an issue.
Question from one of our Olympic doctors about trying to prevent heat exhaustion or heat illness by pre-cooling with things like ice vests. Is that a strategy used in the military and in US athletes?
Yeah, John, that's a great observation. And I think that it's clearly used by US athletes. The idea of pre-cooling, you certainly see it in marathoners, people who are long distance using cooling vests, before the race to keep them cool. And I think there's evidence behind that to show that not only will it lower your risk for heat illness, but it will actually improve performance. I've not seen it in the military. What we're leveraging more is intra-event cooling strategies. I mentioned with slush, the arm immersion cooling systems, running through showers and things like that. So not as much pre-cooling in the military. The one issue I think you face with elite athletes with pre-cooling is it's got to be something trained. Obviously, if you're dealing with someone like a sprinter and you pre-cool them, those muscles may not fire properly. So it's something that's got to be practiced and rehearsed because you certainly don't want to decrement those muscles to fire when they need them.
Fair enough. Two questions on rhabdo. The first is your unexplained first episode of rhabdo, not the extreme one, the sort of fulminant one you described, CK levels of 600,000. But it's not unusual for us in a clinic scenario to get patients presenting and they're at 30, 40, 70, 80,000 perhaps. Now, once you've managed that acute episode, what are the questions you should be asking yourself as a clinician? What is the process to go through into potentially eliminating those causes of the perfect storm that you described? Well, give us a sort of strategy that you use in your office.
Okay, so John, I would strongly recommend, and I'll send it to you if you don't have it, is our guideline. We just updated this 2020 guideline, and we have a rather detailed approach to this. I am going back with that soldier, that athlete, to look for all those risk factors, whether it's going to be a dietary supplement, whether or not it's going to be a new load that they've identified, some new intensity. Did they have a current illness? Was there sleep deprivation? Did they have an argument with their girlfriend They didn't sleep that night. Were they drinking over the weekend? I'm looking for anything that's going to be some change that's going to give me some reason. Now, on the other hand, if it's completely unexplained, then I'm looking for what was the load. And the people who make me nervous as a military physician are those individuals who have a rhabdo with a relatively low load, okay, or a moderate load. They get my attention. We then have a very detailed algorithm that I know Dr. Patricios will share with you in terms of what our evaluation is. I'm looking to see that that CK is going to return to normal under 1,000 within 2 to 4 weeks with rest. If I have a failure of that CK to return to 1,000 and they've got a high resting CK, I'm starting to think about a metabolic myopathy. In addition to that, I'm doing a detailed family history, personal history for things that might suggest malignant hyperthermia, might be suggesting metabolic myopathy in a family member. So it's a fairly detailed evaluation. These are guys, John and gals, that I generally take the time, to listen to the story. What were the risk factors? What was the load, and trying to marry it up. In the military, the United States military, if you have a rhabdo, John, like you said, 80,000, they went out, they did 100 pull-ups with their buddy. We will generally give people a pass, on that first rhabdo event, is in particular if there's a good reason. But if in the military you show us a second rhabdo event, now you got my attention, that you didn't listen to your body, and we start entertaining our evaluation with our metabolic workup pathway. We are very fortunate, John. We have once a month, we have a group of clinicians that get together. And I don't know if you have something like this, John. We've got neuromuscular specialists, cardiologists, anesthesiologists, sports medicine physicians, and we get together as a group and we adjudicate about 20 cases a month. And we talk about these heat strokes and these rhabdos, and we make clinical decisions as a group, looking at them on what are going to be the next steps with evaluation, whether it's a neuromuscular workup, are we going to do a muscle biopsy, or are we going to give this individual a pass? It's complex, not simple, which is why we have an algorithm written down.
Summarize it well, and with your permission, we will distribute that algorithm if we may, because I think it'll be
yes,
very
sir.
useful. That'd be great. And last question, also on rhabdo, do you have a threshold for return to exercise from a CK level point of view? Do you have clinical criteria? When do you give the green light to say start the process again? And then what is that process? Is it a graduated one? What are the conditions you set for that?
Another great question, John. And once again, I'm going to turn to our guideline because we have it all written down there in terms of our green light and our return to duty algorithm. So it's all written down. I could belabor it at this point in time. I would reference not only our guideline, but Kyle Smoot. Kyle Smoot dealt with that University of Iowa cohort, that mini epidemic, and those kids doing 100 squats. He's done a lot of research in this area as well, and he's published on this. So if you reference in PubMed, Kyle Smoot's article on return, that's another great reference. But I'm looking for someone who's asymptomatic, they're feeling better. Their CK, I generally like to see that CK down below 5 times the baseline, which is generally going to be under 1,500 to 1,000. The other thing that's very important is that individual doesn't go back out to rejoin the team, but they go back out to start to re-exercise, acclimatize. The thing that I have seen, John, that I worry about is that some kids will go back from rhabdo too soon and they bounce and they have a second event. And now all of a sudden they've dug themselves into a hole in the military, which can be problematic. But we continue to work on that. In fact, I just got some feedback, John, from one of our sports medicine colleagues down in the Marine Corps who said, Fran, I think I can tweak our return to duty algorithm in Marines, something a little more realistic. So we continue to work that, John, at this point. I hope that helps.
That'll be a great guide. So I can only thank you very much for the time, for the preparation in putting this lecture together. It's been hugely informative. Wonderful comments coming through on the chat group here. People are really, really appreciative of opening our eyes. I mean, there's not many of us that have a cohort of 1 million active individuals that we can turn to for research and for a learning experience like you have. So to be able to tap into that this evening has been a real privilege, and we thank you for that very much. And hopefully we can put that into practice at our universities and schools to the betterment of our athletes. So thank you very much, Fran, we appreciate it. And we hope to see you in action live again, hopefully in South Africa sometime.
Anytime. Thank you very much, John. You have a great day.
You. Have a good day. Great.
Right, bye-bye.
Good. And thanks to everybody for attending another Worldwide WiSH. We really appreciate the excellent questions which came through, and we look forward to your attendance at the next one. And you can see it up here: exercise training, a lifestyle, some exercise, some excellent advice that you're going to be given about how to run healthily and how to run effectively and incorporate exercise in your life. So that's Wednesday, the 7th of October at 6 o'clock, back to a 6 o'clock start time. Again, thank you to Acino and Lita Pharmaceuticals, manufacturers of Zepho, for sponsoring this webinar. And thanks for Robin Saggers for being in the background. Thanks for all of you for attending. To our partners at SASMA, thanks very much for always supporting these. And we look forward to seeing you again on the 7th of October. Click on the link for your CPD points and you should receive your certificate in the next 10 days or so. So have a great evening and see you soon. Bye-bye.